क्या बोले अर्चना मैडम, क्या बोले?
No, I've joined.
Oh, welcome madam, good evening.
Good evening.
Thank you, ma'am. Thank you.
Okay.
Shall we start?
Hi, Archana.
हेलो एक्चुअली मैंने मोबाइल से आई थिंक किया है तो थोड़ा मुझे इशू आएगा लोगों को देखने में।
हम देख रहे हैं आप।
हाँ, आप देखो।
Okay, then fine. Good evening, everyone.
Good evening, Archana.
Secretary Ratlam Obsgyn Society, with our President Dr. Manisha Maheshwari ma'am, and the whole Ratlam family, take the pleasure of welcoming everyone to this webinar today. During these auspicious days of Navratri, for those who are fasting or not, we bring this academic treat. Today we have with us all the stalwarts of Foxy. So we'll definitely relish the session. To start with, I invite our President, Dr. Manisha Maheshwari ma'am, for her welcome address. Welcome, ma'am.
Thank you. Good evening, everyone.
Good evening.
I bring warm greetings from Ratlam Society for today's virtual academic feast on very important topic of anemia in pregnancy. At first, I would like to pay tribute and respect to our late Dr. Ratna Kaul Madam, who was a great teacher and academician, and to pay tribute, I would like to keep silence for 30 seconds. As Dr. Neha has said, today we have stalwarts of Foxy amongst us. I extend hearty welcome to our chief guest, Dr. Shanta Kumari Ma'am, President-elect Foxy 2021. It's my pleasure to welcome guests of honor, Dr. Archana Verma Madam, Vice President-elect 2021, and Dr. Asha Bakshi Ma'am, Vice President Foxy-elect 21-22. I warmly welcome Chairperson, our own Padma Shri, respected Dr. Leela Joshi Madam, and I take the opportunity to wish her a very, very happy birthday, Madam. She has completed 82 years. I wish her good health. I welcome and invite our guest faculty, Dr. Ritu Khanna Madam. She is Chairperson-elect Foxy, Food and Drug Medico-Surgical Equipment Committee. I would invite and welcome all members of Ratlam Society and other participants of today's meeting. Now I take the privilege to introduce Professor Shanta Kumari Madam. Madam is MD DNB FICOG, FRCPI Ireland, FRCOG UK. She is President-elect Foxy 2021, Senior Consultant Obsgyny and Laparoscopic Surgeon Yashoda Hospital, Somajiguda, Hyderabad. She has served Foxy as Chairperson Foxy ICOG 2018, Secretary ICOG 2015 to 17, Member FIGO Working Group on Violence Against Women 2015-2021. She was Vice President Foxy 2013, Secretary TCOX 2015 to 2019, IAGE Managing Committee Member 2015 to 19, Chairperson MNN RRC Foxy Committee 2008-2010. She has many awards and achievements to her credit, like FRCOG UK 2018, FRCPI of Royal College of Physicians of Ireland, ICOG Secretary 15 to 17. She initiated a very important Dhira, a socio-medical campaign to eliminate violence against women. She was National Corresponding Editor for Jogi 2011-2013, Vice President Foxy 13, Secretary TICOX 2017-19. She was awarded CL Zaveri Award and Young Scientist Award. She arranged and organized many conferences, AICOG 2011, for which she was organizing secretary, ICI 2012, Foxy Figo 2013 and even 17, ICPH RP 2015, Foxy ICOG FRC 2016, Foxy ICOG PPP 2018, and Foxy TAIOG 2019. Madam Shanta Kumari, I welcome you. The dais is yours. Kindly say a few words of wisdom to us.
Good evening. Indeed, a pleasure to be here at Ratlam. Thank you, Manisha and Neha, for inviting me to your CME. And I wish to actually wish Madam a very happy birthday. Very nice to know that it's her birthday today. Wish you very many years of more healthy and I think very active life, Madam. Very happy to know that today is your birthday. And dear friends, yes, indeed, today is a special day where Madam is 82 years. And I'm sure Madam will agree with me that she must be talking about anemia from the time she became a doctor. That is, I think, the past 60 years, Madam must have been talking and hearing about anemia. And still, unfortunately, we still have to still talk about anemia. Let's hope by the time Madam comes to her next, maybe I can give another 85th birthday, we'll say. Let's hope we can conquer anemia. I don't want to say Madam's 100th birthday, we will celebrate with the anemia conquerance. We don't want to wait so long. Hopefully, another 2-3 years at least, let's hope that we can reduce the burden of anemia. I was in a meeting recently where we were talking about anemia. We have always heard of anemia, which is 50 to 60%. 70 plus years of independence, and we are still talking of anemia, which is more than 50%, is something very unfortunate. I think it is time that we question ourselves, we question our government, our health minister, our ministry, everything. I think everyone needs an accountability because we have been talking about anemia eradication and anemia management right from the 5-year plans, which we used to read in our school. And now we have seen the anemia book, Bharat. You know, it's a beautiful document that everything, and anemia is not a disease like COVID or Corona where you're still wondering what the treatment is, what to do and all. We all know the simple test and we all know the simple treatment. But in spite of it, I am not able to understand why we are not able to conquer anemia. Maybe is it a lack of commitment on our side, lack of commitment on the side of the government, the doctors, everyone. I think it's time to introspect and question ourselves and question our health ministry also. I'm very, very clear about it that we need to have an understanding why we are not able to conquer anemia. So that is going to be a very big question, and I'm sure Ritu is going to talk. But all our talking, all our listening, and all our doing, and still we're not able to conquer anemia. So I think now the commitment or whatever happens from all sides, it has to be focused and fully applicable to the problem. Yes, this year probably would have had much progress, but unfortunately the focus was directed against a pandemic. But let's hope that in the coming years, when we are able to conquer this pandemic, and then we are going to go back to try to eradicate this perennial problem of anemia. Before actually we overcome the anemia pandemic, we have to face a new pandemic. So that's the unfortunate state of situation. And I hope that we find answers to this anemia. And in very near future, I wish there comes a day where our conferences and our webinars at CMEs do not have to have a topic on anemia. Right? Just waiting for that day, and that will be the real victory of all of us. I would like to know, how is the prevalence of anemia in your society, Ratlam? Can Dr. Manisha or Neha or anybody answer? Is it what's the incidence and prevalence of anemia in your part of the country? Manisha, we can't hear you. Unmute.
Madam, in Ratlam, tribal area, there is a tribal area beside us, and we are having anemia is rampant here. Madam will tell her work where you will know that little children have a hemoglobin of 6, 7, malnourished, Very bad situation, madam.
Yeah, I think so. That shows how terrible. But see, I can understand there's some small belts like tribal areas and the rural pockets having anemia. I don't think I can have an answer why we are having anemia all over the country. We have anemia in AP, Telangana, supposed to be quite well-to-do population. So there is inherent something which is lacking, and why the millions and millions of rupees of the government which is being put into anemia eradication program, why is it that we have not able to find an reduction in the anemia? It is not an difficult task. We know it's a simple correction of the hemoglobin by iron supplementation, but still we are not able to do it. So I think we have to now look at accountability and answer why we are not able to overcome this. See, we ourselves can't do everything, but when the government is also doing so much, the public sector, private sector, NGOs, everyone is trying to do. But in spite of it, why? So I think we need to think about this and then try to find the answers. Thank you very much.
Thank you, madam. Now I call upon Dr. Neha to take the proceedings further, please.
Thank you, ma'am. With lots of thanks and a heart full of gratitude, I thank our chief guest, respected Shanta Kumari ma'am, for sparing time from her busy schedule and accepting our invitation to be at Ratlam. Thank you once again, ma'am. To enlighten us with their presence, we have two very lovely personalities as guests of honor today. The very dynamic and very adorable Dr. Archana Verma ma'am. Ma'am is passionate about creating awareness on women health. Ma'am is the Vice President elect Foxy 21. She is MBBS, MD, FICOG, and Associate Member of RCOG. Past President Ghaziabad Obsgyn Society, Organizing Secretary of North Zone Yuva Foxy, Organizing Secretary of UP ISAR. She is Organizing Secretary of MID Term UPCOG, Chairperson Public Awareness Committee, and Member Rotary Lions Ekta Udan BBP. Ma'am has won many awards and she has been a faculty in around 300 plus national and international CMEs. Welcome, ma'am. Ma'am, I welcome you to Ratlam. We all Foxians would love to hear your view on the topic.
Thank you, Neha. And Ratlam is really very close to my heart since I joined as a public awareness committee chairperson. And my respect to all every seniors and Dr. Madam Leela Joshi and Dr. Shanta Madam. I really wanted to meet Dr. Leela Joshi in 2018 when Dolly Mehra was the president, and how badly I wanted to felicitate her as a woman of substance. Because I had so much of daily we used to talk with each other, and I was so much impressed with the Ratlam and Dr. Leela Joshi, and she said, Archana, if you can give time and you can work nicely, then you will do wonders in public awareness committee. And she really supported me. And I'm so happy to be here today. Thank you, Neha. And like for anemia, Dr. Shanta Madam has really said that 50 to 70% of our adolescent girls are definitely suffering from anemia. When we talk about the urban and quite well-to-do families also, they also have anemia. What are the cause? We know majority, so many times there are psychological effects also. मैं तो ये नहीं करती, मैं तो वो नहीं करती. And मध्य प्रदेश में तो we all know, and उत्तर प्रदेश में there is a lot of a diet problem and nutrition problem. So these are being tackled, and I think we will be doing much awareness about it, and things are getting improved by doing so much of everything. And even one cannot even think of admissions in anemia, but still we require admissions in anemia also, and that is the worst part. And every pregnancy, almost the main complication anemia is behind, and हर complication anemia के ऊपर ही ride कर रहा होता है. So that is anemia is a rider of every problem. So we need to tackle it. Really very good webinar has been planned, and I think हम लोगों को ना छोटा छोटा basic चीज ही मेनली इंडिया में इसको प्राइम इम्पोर्टेंस देना चाहिए, और हर उसमें एक छोटा सा टॉपिक वुमेन वायलेंस का और एक छोटा सा टॉपिक एनीमिया का, जो कि इतना ज्यादा कॉमन है. वी शुड नॉट ट्राई टू गो फॉर अपर बड़ा चीजें, बट मेजोरिटी 80% को तो थोड़ा इस पे ही रहने की जरूरत है. एंड हाउ कैन वी डू विद मिनिमम्स, छोटी छोटी चीजों से, बहुत एक्सपेंसिव भी ना हो. जो आयरन की गोली, यू नो, फॉर वुमेन एम्पावरमेंट वी वांट आयरन लेडीज, बट वी वांट आयरन also. So this iron tablets are not so costly, but it has to, instead, even if they think कि हम after every menses we are going to take 30 tablets of iron, I think that will do. So thank you very much, and Neha and Manisha, thank you very much. And a salute to Leela Joshi madam. I would love to meet her and hug her also. And really sad for Ratna Kaul madam, and my heartfelt condolences for the whole family, and thank you.
Thank you, ma'am. Our second guest of honor is our own, the pride of MP, the composed and passionate dear Dr. Asha Bakshi ma'am. Ma'am, we request to have your words of wisdom.
Thanks, Neha. Am I visible? Because I had to go to my, I'm now connected through my mobile.
Yes,
yes, you are very much beautiful, Dr. Asha, you are visible.
No, because before that I was connecting through the laptop, but something went wrong. The connection is not coming well. So anyway, thank you so much, Ratlam Society, for inviting me today. And actually, after I won my election, I was not well, and it is for the first time. It is my public appearance. So thank you so much that I'm able to attend it today. And I would like to thank you all for all the support you people extended to me during the election. And today, the topic that you have selected is a really good topic. We think that anemia means nothing, but I think anemia means everything. Every patient, whether she is pregnant, whether she has delivered, whether she is a young girl, whether she is undergoing hysterectomy, any surgery, for every patient, it is important that she does not have anemia, and that will really help in having good quality of life. And even your surgery, if your patient is really with good hemoglobin, the post-op recovery is very good. So I think it's very, very important that we have this awareness of anemia and we eradicate this problem at all. Everyone should have hemoglobin more than 12. I think that should be our aim. So all the best, and I'm sure Dr. Ritu is going to do justice to it. And I'm so happy to see Leela madam on her birthday. I wish her a very happy birthday, and I think we should not lose any more time and just go ahead. Thank you.
Thank you, ma'am. That was lovely. Dr. Asha ma'am is the director of Disha Fertility and Surgical Center, Indore, and lead consultant at Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital. She is the joint secretary of ISAR 2021, founder chairperson of MPIAGE, chairperson of
I think don't waste time in this and just go ahead with your presentation.
Okay, ma'am, congratulations for being the vice president elect.
Thank you so much. Okay.
Thank you, ma'am. To chair the session, today we have our very own, very respected Padma Shri Dr. Leela Joshi ma'am, the best person to chair this topic because madam has herself done immense work for eradication of anemia with special emphasis on IV iron use. Ma'am has been confirmed Padma Shri in 2019. She retired as CMD Indian Railways in 1996 and settled in Ratlam after retirement. Ma'am is being in a transferable job, established and founder of 3 branches of Foxy, Kota, Dehradun and Ratlam. For Ratlam, I thank you so much, ma'am. Some of the honors and awards besides Padma Shri are 100 Women Achiever, Women Pride Award, Pride of Foxy, Artist Reality Award for translating research into action, and Dr. Durusha Community Service Award. I welcome you, ma'am. Finally, with a warm heart and open arms, I invite our speaker, Dr. Ritu Khanna ma'am, for her talk. Ritu ma'am has been in organizational position and chairperson elect Foxy Food and Drug Medical Legal Surgical Equipment Committee. She is the secretary Society of Fetal Medicine Varanasi chapter, vice chairperson Women Doctors Wing IMA branch, vice president VOGS, secretary VOGS, joint treasurer Indian Fertility Society, co-convener in SIG IFS ultrasound. मैम इतनी पढ़ाई नहीं करी मैंने जितना मैं सीवी पढ़ पाऊँ.
I think we can make it very short. Go ahead.
And has been awarded with Best Chapter Award as Secretary IFS UP chapter. She has many publications, and her special field of interest is laparoscopy and hysteroscopy, fertility enhancing surgeries, USG, color Doppler, 3D, 4D, ultrasound, IVF, XC. Her center is recognized by Foxy for infertility training. Welcome, ma'am. The stage is all yours.
Thank you. Thank you so much, Dr. Neha, for the very kind words. And thank you, Dr. Leela Joshi, madam, for being the chairperson for this session. And my heartiest congratulations to you and wishing you a very, very happy birthday. It's such a pleasure to be here on this day. My gratitude to the chief guest, Dr. Shanta Kumari ma'am, the president-elect Foxy, and also the guest of honors, Dr. Archana Verma ma'am, the Foxy vice president-elect North Zone, and Dr. Akshay Bakshi ma'am, who's the Foxy vice president-elect for the West Zone. Special thanks to Dr. Manisha, the sweet, smiling president of Ratlam Obsgyn Society, and Dr. Neha, the energetic and dynamic secretary of Ratlam Society. And I'm so thankful for this kind invitation. And in fact, it's really an honor for me. It's your love, it's your affection, which has really brought me here. And Ratlam Society as such is so close to our heart, and we feel at home with you, and the love and hospitality, of course, we can never forget. And thank you also for all the supports in my election for the chairperson of Food and Drug Committee also. So I would like to begin with this topic on tackling anemia in pregnancy. And as we said, we want to eradicate it. It's quite a lengthy affair. You could just tell me if I would need to stop anywhere. So tackling anemia, if you see to the prevalence of anemia, 1.97 billion people are affected globally, and out of it, 50 to 60% of the cases attributable to iron deficiency. If you go to the neighboring countries and see in the South Asia, 53% of the pregnant women are anemic and 3.8% severely anemic. India ranks miserably at 170th in terms of anemia and prevalence in women. Now, if you look at this chart, there's a high prevalence not only in the reproductive or the pregnant, but I think in all the age groups. They're all above 50. So it's a high incidence and also responsible for maternal deaths. Going into much more statistics of India, 1 out of every 2 pregnant women are anemic, and 50 to 60% prevalence, and according to IDA, 80 to 90%, and accounting for 20% of the maternal deaths. If we see the National Family Health Survey, we find if we compare of 2005, 6 and 16, we find that I think the rural area has much more than the urban, but when 2005, 6 and 16 you compare, there is a decrease, but yet it is still high as such in all the parts. So coming to the definition, a condition where the circulating levels of hemoglobin are qualitatively and quantitatively lower than normal, CDC says it's less than 11 in the first trimester and 10.5 in second and less than 11 again in the third trimester. And WHO says it's less than 11. Again, WHO divides it into the mild, moderate, severe, 10 to 10.9, 7 to 9.9, and less than 7. And also the WHO says it's postpartum anemia if it's less than 10. Requirements we know during pregnancy is 3 times higher as it increases as the pregnancy is going to progress. If you see that the total extra that you require, the iron in pregnancy, it's around 800 to 1000 milligrams, and we have distribution for the fetus and the placenta and the red cell mass and also the loss during the delivery and all going on. So the average daily requirement that's been calculated in the first trimester is 0.8 milligrams per day, and it increases to 7.5 milligrams per day in the third trimester. The average daily absorption, if you take a Western diet, is 1 to 5, and if you take an Indian diet, it's 0.8 to 3.5. The daily iron supplementation that we require is 30 milligram as by CDC and 60 milligram by WHO, up to 28% being absorbed. But we need to remember that during pregnancy, the plasma volume increases by this 45 to 50%, and the RBCs increase by 20 to 30%. So here is where we are lying. There is a hemodilution. So if a hemoglobin was there as 15, it could even come back to 12 because of this reason. And if you see the iron parameters, what happens is during the first and the second trimester, the iron and the ferritin, both of them decrease drastically. And in the third, they become static. So there's a deficiency of the maternal iron storage and results in the deficiency of neonatal iron storage. The normal diet contains about 14 milligrams. Out of it, the absorption is just 5 to 10%, that 1 to 2 milligram, and 3 to 4% in a pure veg diet. Additional iron requirement or a demand in pregnancy is 2 to 3. In the late pregnancy, 6 to 7. So the daily supplementation is also increased by 400 to 600. And if we look into the various causes, we know it could be hemolysis, it could be hemoglobin synthesis being abnormal. We have different types of anemias. We have malaria, we have G6PD. There could be loss, there could be defective iron absorption affecting the metabolism. So all these conditions were familiar. There could be certain chronic conditions we need to take care of, tuberculosis or the renal disease or the urinary tract or the HIV and rheumatic and recurrent UTI also. But we cannot forget the physiological factors, the pregnancy, the menstrual blood loss, the malabsorption, as well as aging. So the definitive diagnosis, of course, it's by the hemoglobin that we measure, but there are other signs, pallor in the inner rims of the eyelid, tongue, and of course the overall skin, nails, palms of the hand. There could be changes in the nails, there could be chelosis, glossitis, stomatitis, edema, and also in hyperdynamic circulation. You may get a soft systolic murmur that we need to differentiate and find Krebs. So when she has a mild anemia, we do not detect because it's asymptomatic, but she starts developing further weakness, fatigue, loss of appetite, exhaustion and indigestion and all these things. It's a moderate. And then she has palpitation, tachycardia, if it's not treated, breathlessness, and general anesthesia and pulmonary edema, which is the severe one. So just we get into our lab investigations. What really do we need to do? Is a hemoglobin just sufficient? No, we need to do a complete blood count and also the serum iron, the binding capacity, the ferritin, the transferrin, the reticulocyte, and a peripheral blood smear is very, very important. The stool and urine examination could be added, and of course proteins and few other tests. I think the thyroid, the urinary tract infection should also be looked into. Just focusing on the complete blood count. It's red cell count and the indices. Count is a hemoglobin, the hematocrit, and the reticulocyte, and we have the indices with us, MCV, MCH, MCHC, and the RDW. Now, apart from this, the RBCs, we have white blood cells, differential count, the nucleus segmentation of the neutrophils, and the platelet we should look into because we really do not know whether the anemia is due to this or it could be due to other factors. The size, hemoglobin count, anisocytosis, poikilo, and polychromasia. Now, if we do a morphological classification, that's very important and it's very, very clinically useful. Just use the MCV. You divide it into micro, normo, and a macro. That's in femtoliters, MCV less than 80, it's micro, it's 80 to 100, it's normo, and more than 100, macro. If it's less than 80, the differential could be, it could be iron deficiency, it could be thalassemia, chronic or acute inflammation, chronic disease, or hypometabolic states. If it is between 80 to 100, then you need to subclassify. Go in for the next test, and that is the reticulocyte count. If it is more than 2%, then it's a hyperproliferative state. So the circulating reticulocytes are a part of the compensatory mechanisms as to the increased destruction or the loss of RBCs. The cause is usually due to acute blood loss or hemolysis. And if it's hypo, that means the reticulocytes are less than 2, and there's a decreased RBC production. Let's take the third category, and that's macrocytic. That's more than 100 femtoliters. That can be again divided. It could be either megaloblastic or a non-megaloblastic. A megaloblastic means a deficiency of DNA production or maturation resulting in appearance of immature RBCs. So there, when we look into the smear, we get a megaloblast, and also we get hypersegmented neutrophils. That is the importance of seeing this, both of these. And in non-megaloblastic, we will not be getting this. So we have done it according to the MCV. Now, we must remember that the first change is the depletion of the iron store, your bone marrow, liver, the spleen, and they can take few days to months. They are depleting. How do you know? It's reflected in the ferritin levels. Later on, the serum iron falls, the percentage of saturation of transferrin falls, and the total iron binding capacity now increases, and the unbound transferrin increases. And then we find the fall in hemoglobin and PCV, which occurs in 2 weeks. So another parameter that you should note is the cell protoporphyrin. Why? Because it's an intermediate in the pathway of the heme synthesis. And if the heme synthesis is impaired, what will happen is there's going to be an increase in the protoporphyrin. So it's normally 30, but in iron deficiency, it would go even up to 100 micrograms. What is the utility value? The gist of all this was that your iron stores are the first to be depleting. So it's the ferritin that you need to focus on. It's best for the estimation of iron stores. 30 microgram per liter is the normal. If it is 20, 15, now be careful when it goes less than 15. It would deplete. Your stores are going down and getting absent. So what I wanted to say is there is a spectrum of iron deficiency. It's an iron. This is the storage and this is the transport and function. What initially would happen is your stores decrease. Then there is an iron deficit phase and there's erythropoiesis to compensate. And lastly, when you're detecting by hemoglobin, that's where you come to an iron deficiency anemia state. And if you go into the figures, this should be 20. It's 20 and then 15 and 15, and subsequently how these figures go. So the 3 stages was there is a negative iron balance, demand more than ability to absorb, like in pregnancy. Iron is now mobilized from the stores. So there is a decreased ferritin, and we noted it that there's a decreased enable iron in the bone marrow. And TIBC, serum iron, protoporphyrin, they'll still remain normal. What's the second phase? After the iron stores deplete, the serum iron is now falling. The TIBC increases, the protoporphyrin increases, the bone marrow stores are absent. When the ferritin is falling below 15, we have to be high on the alert, and hemoglobin is still normal. The iron would be. And the third phase is when it's hemoglobin, which is falling, and the PCV falls. So now it's gone into severe anemia. Hyperchromic microcytic reticulocytes, target cells, poikilocytes, all have appeared. And symptoms now fatigue, pallor, reduced exercise capacity. And in advanced stages, it may go to chelosis and koilonychia also. So this is a beautiful chart, says, how do you move? See, we've gone from a negative to iron deficit to an iron deficit anemia, and marrow is 0. The serum ferritin less than 15, serum iron has gone down, the TIBC is up, the protoporphyrin is up, the saturation is down. And the picture is a microcytic hyperchromic anemia, which is seen over here. Now, so there's a history, there's a physical examination, we've gone to the lab findings, and so a low serum iron, the TIBC is elevated, a low ferritin brings us to iron deficiency anemia. But with this picture, still do we need to differentiate from the other anemias which have got MCV low? Yes. We need to differentiate these from thalassemia, the chronic inflammation or the acute inflammation, the chronic disease, and the anemia of the hypometabolic states. So let's put our conditions into this chart. We find that in the tissue iron deficiency, which is without anemia, your hemoglobin will be normal. Iron deficiency anemia, we've already gone through all these parameters. And anemia of the chronic disease, we will find that the ferritin will be normal or elevated. Ferritin dose is not empty, the elevated iron stores. Further, if we go, we find that there would be target cells. There would be an elevated reticulocyte count. And also you could do a hemoglobin electrophoresis to confirm whether it's not a thalassemia or to differentiate. So when we go by the ferritin, it's less than 15 to 30. Of course, it's a confirmed iron deficiency anemia. But if it is between 15 to 30 and less than 100, it could not be a confirmed, but it's possibly the iron deficiency anemia. And deficiency is not excluded in presence of inflammation, chronic disease, or a high C-reactive. So you consider the clinical context, seek the advice, do a blood film, and find out the other causes. And if it is more than 100, iron deficiency is unlikely. And it may still be present of chronic disease or chronic disease. Transferase saturation would be less than 20. And so this is how we go on. And when we have the macro, we have the megaloblastic and the non-megaloblastic. We do our vitamin B12 levels, which are decreased. And of course, we differentiate by this, and we have to do a serum folic acid levels too. So these are the non-megaloblastic. Cytogenetics and genetic testing needs to be done. So the carry-on message from the first part of the talk is that you go by the MCV and accordingly move. All pregnant women must be screened for anemia and treated if necessary. The very, very critical periods of pregnancy, 28 to 30 weeks, the labor, the immediately after delivery, the early puerperium are very important. And what is the effect on the mother? Now she's at a high risk of what? It's the preeclampsia, the abruptio, the preterm. She is going to be predisposed now to infections. The urinary tract, the sepsis, there's going to be increased risk for PPH. The uterus may not involute. Lactation may be trouble. There may be failure or even maternal mortality, CHF, anoxia, and sepsis. So we need to take care. If she's going through the labor process, it may be possible that there's a prolonged labor, increased rates of an operative delivery, or fetal distress, or an abruption. Let's not forget the postpartum. She may end up into palpitation, tiredness, shortness of breath. There may be emotional and cognitive defects, instability. There's a decreased cognition, and she's at a risk of a very high postpartum depression. There could be reduced milk production that could also affect her psychology again, and resulting in shortening periods of lactation. We cannot forget the fetus. It could be preterm. There may be low birth weight newborns. There could be possibility it's an IUD suddenly. It's low AFGAS score. Neonate may be more prone to infections because of the anemia in the mother, and a high prenatal and perinatal mobility and mortality. In moderate, it's had 5 times the rate of perinatal and 3 times the stillbirth in those with hemoglobin less than 11. There could be changes in infants' brain secondary to this deficiency. It can affect the brain growth, the myelination, the neurotransmitters, and even the brain programming. And what else could happen is it could be affected with the major, and they could be non-reversible motor neuro changes in infants and children who are being born, and rates of stunting may increase. So we really we are focusing, and because it's not only one, because 2 lives to be involved and cared for. If we come to the management now, take care of the underlying cause. Good dietary nutritional interventions. We must know she needs around 2,580 calories. And this is a beautiful chart which we can make and give it to her. It's a timing, and it's what exactly should be into a chart to have this full nutrition. And look at this pyramid, the cereals and grains being at the bottom, and how many portions, 3 to 4 portions per day of vegetable, of the fruits, proteins 3 to 4 per day, dairy products, and the fats, sugar, oils lie at the top tip of this triangular pyramid. So this is how she has to go along. And yes, the promotion of consumption of iron-rich foods, meat, fish, poultry, non-animal foods, legumes, and green vegetables are recommended by WHO. Inhibitors to be taken care of, and enhancers also to be taken care of. Treatment options we have the oral therapy, the parenteral, and the iron therapy. We have there the best, and the best way is the oral therapy. If they do not tolerate, we go to parenteral. Transfusions are not universally accepted, but yes, sometimes we need to do them. So let's take up and see what is into this oral iron therapy. WHO says if it's a prophylaxis, you give 60 milligrams and 400 micrograms of folic acid till term. If she needs a treatment, you double it, 120 and 400 folic acid till term. If it's postpartum, you come back again to 60 milligrams of iron and 400 for another 3 months. The Ministry of Health and Family Affairs says it's 100 milligram what we are taking, and iron is 500 microgram folic acid for 6 months. If it's mild anemia, she needs 2 tablets to be done of these. If it's moderate, you can either give her intramuscular iron therapy, or in severe, the IV sucrose, and postpartum again the 100 milligrams and 500 to be continued. Do remember to deworm all the anemic patients. We have different classes of these iron salts. What we were using were the inorganic salts. It was a ferrous sulfate we used a lot. Then the fumarates, ammonium citrate, ferric ascorbate. Importance to ferrous sulfate and the ascorbate. We have the organic, where we have the ferric polymaltose. The minerals, that is carbonyl iron, elemental iron, chelated ones with biglycinate, and the technology advanced iron salts, which are the ferrous ascorbate, as well as the sucrosomial iron that we have now. So it depends upon the dose, the status, the form, the stability, and the elemental, and also the bioavailability of the iron. Let's go into this oral iron therapy. We said prophylactic, what is the dose, and the treatment, what is the dose, and do a deworming. Yes, benefits, they are inexpensive. They can be used throughout her life. She can even keep using it, but limitations would be with the GI effects and the adverse effects and the adherence, the compliance, and that is the worst. You have to counsel them a lot and check into whether they are really taking them. Now we have the bivalent iron salts, that is the ferrous sulfate and the fumarate, which were preferred iron preparations, and they were even recommended by WHO. Should have 100 milligrams of this iron readily released in acidic and the neutral pH, and the salt should be readily absorbable, the ferrous form, the best form, infrequent side effects, and should not have several therapeutic agents, and also we need it to be cost effective in our country especially. So this is a list where we have the conventional preparations, and we have the ferrous ascorbate. Then we'll come to the modified release. Then we come to the chelates and the iron polymaltose complex and the carbonyl iron. Ferrous sulfate was the oldest form of iron. The absorption rate is 10 to 15%, and it's reduced by some things like phytates and tannins and all these. We already know of them. Side effects, yes, diarrhea, constipation, nausea, vomiting, backache, and all. These are the things that we already know with the conventional iron. And look at the tea, coffee, and all, which are hindrances to this. We also know the absorption is through the enterocytes of the duodenum and the small intestine. The ferric form converts to ferrous, which enters the enterocyte with the DMT1, that is the divalent metal transporter. The heparin converts this ferrous to ferric, and ferroportin, which is there, it transports the ferric into the blood, and of course the transferrin would carry this ferric towards the bone marrow for erythropoiesis. So importance here is of the ferroportin. We already knew all these limitations of phytates, phenol, tannins, and the acidity that would hamper, which is necessary for absorption, and also the metal ions. And we should know that this hepcidin would restrict in high levels absorption. So the conventional irons, oxidation to poorly soluble ferric forms in distal stomach and intestine, and that's why they'll be poorly soluble chelates they'll form, and of course they'll be attacked by inhibitors, chelations, and 10.4% poor absorption. A lot of unabsorption generates free radicals and attacks the GI, responsible for the GI side effects. Let's come to the newer ones now. So the newer preparations are better tolerated, less side effects, and we have these common preparations: carbonyl ascorbate, iron polymaltase complex, with the bisglycinate, and sodium. So merits are that they've got a better tolerance. They are more than 10 times the dosage of iron. Even if you give them in higher doses, they're not going to affect the person. No food interactions with the newer preparations, and better absorption and compliance is high. If you take the modified preparations, rather, they are improving the GI tolerability and sustain controlled release also. What happens is it contains a polymeric complex, which is now going to surround this iron and to the individual secretions of the GI tract in conformity with the absorptive capacity. So look, what happened is there is an advanced coating technology over here which keeps it protected. Ascorbate is an antioxidant or a reducing agent itself. So high iron reducing, reaching the duodenum now. Then there are sustained release. It's embedded, this ascorbate is now embedded in an HPMC polymer matrix. And what happens is this HPMC absorbs water, it forms a gel, and the tablet sticks to the mucosa over here. Then the polymer particles swell one by one, ensuring that they're going to be released sustainedly. And what happens is first in the 5 hours, then 45% in the 1 hour, then 20% in 3 hours, another 35% in 5 hours. So no dissociation in stomach, absorption of ferrous ions occurs in the intestine. So this is with the technology, the synthetic molecule ascorbic acid will enhance the absorption, and this ascorbate is less easily oxidized than the ferrous sulfate that we were using. So absorption average 52% higher than the ferrous sulfate. So this is oxidizing index much more stable, maintains iron in the highly soluble ferrous form, no dissociation, no inhibitors, absorption as high as 67. Just look into all these compounds over here, and we find that bioavailability is 67% in IDA. And now ferrous glycine sulfate, or the ferrous bisglycinate. Iron is now chelated to amino acid. And look at the beauty. Now it's irrespective of any pH changes. This glycine sulfate maintains the iron in the ferrous form, better absorption, avoids unwanted interactions with any food ingredients. So that's the beauty of chelating it. Absorbed intact, absorbed into the mucosal tissue, the highest bioabsorption, higher bioavailability even in the presence of phytate, stannates, less likely to cause the side effects we are really afraid of when we give it to patients. It does not interact even with the multivitamins. Next, we have an ionic, that is the iron polymaltose complex. It's now a trivalent oral iron. It's been coupled to the sugar complexes. The non-ionic iron now is a stable complex. Absorption, not affected. You can take it with meals and lesser side effects. So it's a pure form of elemental iron, low toxicity, better tolerated, very fine microsphere of less than 5 microns in diameter, better absorbed and associated with less GI side effects, and also available with the modified sustained release preparations. Now let's know the unknown which is there in the iron therapy, and that's a new generation iron. We do not maybe know about hepcidin, iron inflammation. Let's go into it. Which is the factor? Is there any such factor which is regulating the hemostasis in our body? And does it affect the efficacy of iron supplementation? Hepcidin, it's a peptide molecule. It's a master regulator of the iron bioavailability. It's a regulation of the transmembrane iron transport. What does this hepcidin do? It's going to bind to the ferroprotein. It forms a complex with it, which is degraded in the lysosome. And now the iron has been locked. This iron cannot go anywhere. This hepcidin is made in the liver. In response to the iron stores, its regulation goes on. It's induced by interleukin, infections and inflammatory, and it restricts both iron absorption and release in the store forms. Hepcidin is lower in pregnant women. Look how beautifully nature takes us. Hepcidin decreases as the pregnancy is progressing, with the lowest hepcidin levels being observed in the 3rd trimester. You need the most of the iron absorption. The increased need for fetal iron in the 3rd trimester is responsible for the maternal hepcidin, which goes down. We have to be very careful of all the inflammatory states, because what is going to happen is in these high inflammatory states, obesity, gestational diabetes, preeclampsia, malaria, this regulator now it's going to be in higher levels. So what is going to be happen in this is the evidence which shows that you need this level increases. Therefore, the bioavailability would be decreasing and would be compromised. So do take care of the doses in these conditions. And also the CRP and IL-6 levels elevated might downregulate the iron absorption. So be careful of these also. So is there a novel route of iron absorption other than the enterocyte that we already know the transporter-mediated iron? Is it possible? And do we have any iron which is just not or minimizing all the GI side effects? We have irons with an iSeal technology. What has been done is the particles have been micronized, and these micronized particles are in the liposomal bilayer, increasing the absorption with the efficacy. New generation oral iron with the evolutionary covered, that is a phosphobilated layer, and also the sucrose esters also. So this is your iron, that is the ferric pyrophosphate and folic acid. Then there's a phospholipid bilayer and the sucrister. What is the sucrister? It's a surfactant which is derived from the esterification of the fatty acids and has recently been shown to behave as an absorption enhancer because of its ability to reduce intestinal barrier resistance and thus facilitating the paracellular and the transcellular routes. So further stability and coating obtained by adding other ingredients, that is the tricalcium phosphate and starch, and they form a sucrosome. So this sucrosome is very resistant. It's GI resistant and without side effects. So what happens is the sucrosomal iron is there and it is just a vesicle. It's vesicle-like structure now. And this is well tolerated. It's highly bioavailable compared to any conventional iron. If you look into the graph, it's got the highest bioavailability over here. And so this is the beautifully structured iron, and this is the vesicle, how it will go in, and this engulfing intact liposome into the nucleus. And let's see what happens. What is the pathway of absorbing this through it's the M cells. And what are these M cells now? They are nothing but the specialized epithelial cells of the follicle-associated epithelium of the GI tract. Transport of the antigen from the lumen of the small intestine to the mucosal lymphoid tissue directly. So also transport the larger molecules by the endocytosis, as we can see over here. So the M cells mediated translocation is very efficient. It's a very, very rapid process. And this process contents of the endosome do not undergo major structural changes. They are released intact. Why is it so? Because the M cells do not have, they have low lysosomal content and so can transport antigens with almost no enzymatic degradation. So the iron covered by sucrose crosses the gastric acid barrier. It's reached the small intestine in intact form, and this is directly absorbed into the M cells by the endocytosis, which you can beautifully see over here, and the direct transporting the sucrister iron through the lymphatic to reach intact into the liver. And now in the liver, what is going to be happening is it's going to be opened, and then the iron is available. So this trivalent ferric pyrophosphate has high affinity to the newly synthesized transferrin. So this is a unique way where it is gone and it has got less side effects also. And we see that it's able, this technology is able to protect the iron compared to the non-sealed formulation. And it's replace 80% of this iron of acidic pH. Now, these are the differences which we've already mentioned as compared to the conventional iron. And look at this, that highest ferritin levels, and that is what we want as compared to ferric sulfate or ascorbic acid, and sucrosomal iron when compared to the other iron salts also. And it's been found that with sucrosomal iron is faster and more effective in a hemoglobin rise. And when you see, it's around 4 grams per deciliter in 6 weeks with 60 milligram of this sucrosyl iron. And also improvement in hemoglobin and reduction in the CRP levels also. So we find that it's a rapidly absorbed in hemoglobin level in anemic patients and good tolerability as compared to the conventional. But could there be any failure to the response in any therapy at any point of time? Yes. Compliance is the worst you have to take really care of. You have to really dig into her history, how she's taking it, and what is the time and non-compliance, concomitant folic acid deficiency, which we may not have been taken care of, continuous blood loss, or the hookworms or anemic patients need deworming, coexisting infections, faulty iron absorption, inaccurate diagnosis, or as we differentiated, we were missing something into the other microcytic anemias also. The other option with us is what? It's the parenteral iron therapy. These iron agents are spheroid particles with iron core and carbohydrate shells over them, and slow release of this elemental iron, high and rapid dose administration, and the new generation IV techniques will just take up. Indications we all mentioned: not tolerating oral, there's a malabsorption, there's a compliance defect, and routine supplementation, or patients on erythropoietin, or it's a third trimester, we don't have time, we need a rapid restoration, and contraindications, of course, we have hypersensitivity, she's not tolerating anemia to not attributable to iron deficiency or acute chronic infections, and so on. So we have all these complexes, and I'll just take you to the first, second, and third generations. We had iron dextran associated with rare but serious allergic reactions, and the second generation preparations they were given iron dextran was given intramuscular. It's very painful. The iron gluconate and the sucrose only administered in low doses. because of the labile iron complexes, there are more chances of free iron release and subsequent toxicity if they're given in the higher doses. So then we had the third generation. And to differentiate with the third generation, we have ferricarboxymaltose, the iron isomaltoside also with us, and the three unique. What is the difference? Now this one, which is there, is the second generation. It can be administered in low doses with you, and it's because why low doses? It's a very labile iron complexes and more chances of free release and subsequent toxicity if you put them in higher doses. But this didn't happen with the third generation. Why was it? Because it is a unique strong complex structure, and it releases lower levels of labile or a free iron to be given over shorter periods of time. So FCM has got the least labile iron content. And the role of parental, if you take a sucrose injection, 200 milligrams, we put in 100 ml of saline, given to be 15 to 30 minutes. And first your infusion rate is 20 to 30 drops per minute, and then increase it to 80 to 90. And it's not, you don't give your oral iron when you're giving an IV iron therapy. And between the two doses, of course, you could have an interval also of 2 to 4 days. Now with the sucrose iron, there should be a response. You have to check your reticulocyte counts. You can even check your hemoglobin, which should rise, and your reticulocytes also. And how do you calculate the dose? This is by this formula of Canzoni. It's total iron deficit. It's equal to the body weight and what into target hemoglobin minus the actual into 2.4 into 1000. Now, what is this body weight? It has to be a pre-pregnant weight to be used for the body weight. And if the pre-pregnancy weight is not available with you, then the weight recorded during the first visit has to be taken. The target hemoglobin, we take it as 11, and 1000 is what is iron depot in the body of women with weight more than 35. But if the pregnant woman is less than 35, then the iron depot is 15 milligrams per kg. So this is, you just plot it beautifully, and then you can also calculate it. So not associated with the hypersensitivity, you can use this in minor, and you give it in 15 minutes. It releases slowly the iron, and of course it gives you similar to ferritin. It's deposited into the reticular endothelial cells. Test dose you don't require. It's low immunogenic also. So non-dextrose containing drug with a neutral pH, and of course very stable also. So this has a half-life of just 7 to 12 hours. Repeated administration could also be done. It won't result into any accumulation. And also you could give it to patients of CHF, CKD, and IB, and all these patients with heavy uterine bleeding. Sometimes you have no other options. You can give her this iron. So how do you infuse this? This has to be diluted in 0.9% of sodium chloride solution, and it's 20 milligram per kg body weight. If you have a dose that is to be given as 100 to 200, you put it just in 50 milliliters. If it's 200 to 500, then you put in 100 milliliters. You take a time of 6 minutes. But if it is more than 500 to up to 1000, you do dissolve into 250 ml and just infuse in 15 minutes of it. So this is the comparison with other irons. That antigenicity is low. We don't need a test dose, and the time of injection is very, very short as you compare to the other irons. So this could be an option. And yes, whether you need to give it into the first trimester, the studies yet do not establish its safety over there. So we do use it into second and third trimester if the benefit is judged to outweigh the potential risk for both the mother and the fetus. Now we compare over this into the hemoglobins and all with the iron sucrose complex and the FCMs. If we take over here, we find to the mean hemoglobin rise, yes, there is a change in hemoglobin. You compare to both, it's 29 versus 22, change in ferritin, 187 versus 145. And these readings have been taken after 12 weeks. Also, you compare your ferritins before and after this therapy. And you find after 4 weeks, it's 119 as compared to sucrose, which is 34. So definitely better rise in the hemoglobin, and of course the efficacy and safety. We can give it 1,000 milligrams at a shot could be given, and post-treatment, it's been found to be very, very important and very useful in a postpartum anemia. And they were found that the hemoglobin levels were much, much better post-termination at 2 weeks with these iron of FCM compared to the iron sucrose also. And these are the different studies which showed that how much hemoglobin rise does it show? 2, 3, 3.2. So you can find it's giving a good rise of hemoglobin also. So parental iron being compared to iron sucrose with the multiple doses, ferric carboxymaltose, and also the other iron. This takes a longer time of administration, a single dose, shorter time, low risk of hypersensitivity, and even this third iron contained reduced dextron, which is more labile irons as compared to the FCM. Blood transfusion, yes, we do not like it, but yes, rapid effect in emergency situation. We have to consider all the risks and wait with the safeties also. What are the indications? If your patient is less than 34 weeks, hemoglobin is just 5 with or without signs of cardiac failure, or 5 to 7 in the presence of an impending heart failure. Pregnancy, more than 34 weeks, less than 7 grams per deciliter, even without the signs of cardiac failure or hypoxia, and severe anemia with decompensation. Anemia not due to hematinic deficiency, hemoglobinopathy, or bone marrow failures, hematologist has to be consulted. Acute hemorrhage, yes, could be cured with them. And intrapartum, sometimes you may need when it depends upon a history and the symptoms and hemoglobin if it's less than 7, or a postpartum which has a hemorrhage, acute shock, she's gone into shock, and decision would really mean with the symptoms also. Infection prevention and preterm labor management, severe anemia, yes, it predisposes strongly to PTL, prom, and infection, and antibiotics indicated at the onset of the preterm labor or prom, not routinely. And tocolysis, yes, we reserve it in anemic patients also for just the steroid coverage window in uterine for the transfer, and the management of preterm labor must be taken by an experienced obstetrician with a good neonatal support. So let's finally go to the guidelines and the recommendations over here. How much iron and folic acid is required? If you go to the WHO recommendations, uh, uh, now what we do is we have the daily iron and folic acid supplementation with 30 to 60 milligrams of elemental iron and 400 micrograms of folic acid has been recommended to prevent the maternal anemia we talked of earlier. The prophylactic and the therapeutic dose is different. Puerperal sepsis, low birth weight, and preterm. How do we calculate it? 60 milligrams of elemental iron means we have to give 300 milligram of ferrous sulfate hydrate, 180 milligram of ferrous fumarate, or 500 milligram of ferrous gluconate to get a 60 milligram of elemental iron because of the absorption. And next is the WHO says in antenatal, if you need to treat her, then her daily elemental iron should be 120, we've already discussed, until a hemoglobin rises to the 11 gram per liter. And the Foxy GCPR 2017 states in mild to moderate anemia with a period of gestation less than 30 to 32 weeks, and those who respond to a trial of oral therapy, the treatment should go on continuing with 100 milligrams twice daily and 500 grams. We achieve a normalization, a prophylactic daily iron supplementation, then 60 to 100 is recommended for at least 6 months during pregnancy and continued postpartum for another 6 months. Let's go on to the RDA by the ICMR also recommendations. In the pregnant woman, it's 35 milligrams, and lactation 25 milligrams. Above recommendations would assume that the 5 to 8% of iron is absorbed. So we know the increasing requirements. And let's take a look at folic acid also. Dark green leafy vegetables, fruits, cereals, and poultry and meat need to be taken. And the pregnant women require, as per ICMR, 500 micrograms and lactation 300 micrograms. But we need to take care that now, how do we get this 500 micrograms? 1 microgram of food gives you only 0.5 microgram of synthetic. So 500 microgram means you take 250 micrograms of your synthetic folic acid, and thereby you're going to replenish that need. So we come to the national guidelines for the prevention and treatment of anemia in the pregnant women. Anemia Mukt Bharat, that is for prevention prophylaxis of anemia, 100 milligram elemental iron plus 500 micrograms, 1 tablet for 6 months during pregnancy and 6 months postpartum. If she is a mild to moderate anemia, you give her 2 tabs that's containing 100 milligrams and 500 for 6 months. Now, if she has a mild and moderate anemia, the first line, we've already given her 2 tablets. Otherwise, you need to give her parental iron, may be considered as a first line of management, who are detected to be anemic late in the pregnancy or in whom the compliance is likely to be low. If there's no improvement, just send her to a higher center, or if the facility is there, you manage her with IV iron success, ferric carboxymaltose. Severe anemia, she should be hospitalized. If it is third trimester pregnancy, when you have a round-the-clock specialist care is available, and the treatment will be done using IV iron. Either you use a sucrose or use an FCM. Foxy GCPR also says parenteral iron can be an alternative if the mild to moderate anemia pregnant women are non-compliant or intolerant. The parenteral iron are also recommended for pregnant women with severe anemia who are hemodynamically stable. They require rapid restoration of iron stores in the second and third trimester. And of the iron preparations, they recommend iron sucrose, and this is 2017, but now we have the FCM also, but the high quality studies, safety and efficacy of FCM still should be performed. In postpartum anemia patients, parenteral intravenous may be preferred alternative to the oral iron, and FCM has an advantage of being administered in a bolus dose in the postpartum, and you can correct and send her with the corrected anemia requirements home. Folic acid, yes, effects on pregnancy. It could increase the risk of abortion, growth retardation, abruption, preeclampsia, and the folate deficiency. Folate supplements during pregnancy have resulted in increased birth weight in the cases of malnutrition. And WHO says you take 800 micrograms in the antenatal and 600 during lactation. So just take a 5 milligram oral folate tablet would be continued to 4 weeks postpartum. So just to summarize, we have this chart. If she has a hemoglobin less than 11, mild to moderate, early detected in early pregnancy, start her with 2 tabs. Detected later or a poor compliance, give a parenteral iron, sucrose or FCM. Follow up after 1 month, no improvements. Then you have to refer her to another for the further investigations. Improvement is there. You just give her the prophylactic dose and keep counseling her. If she's severe anemia, yes, hospitalization would be required also. And pregnancy is less than 30 weeks, you need to iron deficiency proved, give her oral therapy, intolerance or non-compliance, give her intramuscular, folic acid, iron. 30 to 36 weeks she is reported to you, you give her iron deficiency, you can give her parenteral iron, and also folic acid. If she's come very, very late, it's more than 36 weeks, yes, you need to give her then blood transfusions also would be needed. So I think there were really, really difficult roads right from this phase and going on to her pregnancy and the postpartum. But we had beautiful destinations and this little baby, thanks the doctor for such a loving care and such a perfect management, which brought me here to this earth today, and I'm in this world. So, but still her next remains to get another child in spite of the anemia and fight it to its best. Thank you so much for your patient hearing.
Thank you, ma'am, for the very informative and very useful talk. Shall I take the questions, ma'am?
Yes, yes, Dr. Neha.
Or ma'am wants to conclude.
Dr. Neha?
Yes, ma'am.
Madam can take up. Leela ma'am would be there.
Dr. Leela madam.
Yes,
Dr. Leela madam would like to speak.
Yes, after questions, I will request her to conclude. Or shall I do it before?
You should do it before.
Madam's views and experiences, we would like to have hers also.
But before I request ma'am to conclude, I would like to wish Leela Joshi ma'am a very happy birthday. We all would like to wish the Mother Teresa of Ratlam a very happy birthday. We wish you all the health and happiness in life, ma'am. Leela Joshi ma'am, I would request you as a chairperson to conclude the talk. Welcome, ma'am.
Friends, good evening. And I convey my sincere thanks to all of you who have wished. It is such a pleasant coincidence that in today's seminar is the 28th of October and that is my birthday. Thank you so much to everyone. At the outset, I would like to thank Ratlam Obsgyn Society and Dr. Manisha and Dr. Neha in particular for giving me this opportunity to chair this such an important session of anemia. Dr. Ritu has so extensively and so clearly explained everything in detail that she has not left any room for me to comment upon. So I think I'll start sharing my experiences, some of my experiences of my work on anemia in tribal and underprivileged pregnant mothers and also for the future mothers. I have used the word underprivileged, but in fact, uh, now they are most privileged persons. The problem lies that they don't know how to avail the available privileges, and here lies the ignorance, uneducation, and unawareness, not only in the part of the patient but also in the part of the service givers. I would share some of my pictures of camp to justify what I am telling you. Here is a picture. Here is a picture of one of the camp in remote tribal village of Ratlam district. The camp was organized by one NGO from Delhi, and we were the service giver. There was here is a lady with red garments, and she was standing in the queue for registration of that health camp. I felt something fishy. I had gone to her, I removed her clothes, and she was absolutely white. She was full-term pregnant and white. I made her to sit and got her hemoglobin tested, and she was less than 5 gram, 4 point something gram. So I said, the health workers were also there. I called for Asha worker and asked, what did you do for all these 9 months for this? She said, I have visited her many times, have given her iron tablets, but what to do? She is not taking. So here is the apathetic attitude of the workers as well as the ignorant and reluctant attitude of the patient. What we are trying to say that it is not the lack of resources, it is the availability, it is the non-availability of available resources. I'll share another picture. Here is a girl from a government school at Namli, very near to Ratlam. Girl studying in class 9th. Her hemoglobin was 4.6 gram. As we all know that many times, most of the time, anemia, if unless until there is acute loss of blood, bleeding, trauma, hemorrhages, then of course we have to, they have symptoms and we have to manage it immediately. But anemia, especially the chronic anemia, the body gets so much accustomed that the patient, they do not have any symptoms. But for this, I would really, to some extent, blame the mothers. In every camp of us, I asked every girl, what did you eat? What did you take? And before coming to the school, they say, we have not taken anything. Okay, you have not taken, you must have brought something to eat in the school. They say, no, we have not brought anything, dabba, etc. to in this for the school also. Okay, there is a midday meal they get in the school. So you must be taking that meal. No, we don't even take that meal. So what do? Most of the girls, they say that they go home and then take their meal. Now, we and all the members of our team were worried after all, why do they not take this midday meal in the school? because I have many times witnessed the meals are very good, they are quite tasty, but they don't take it. So we tried to find out why do they not take these meals. We came to know that the mothers told them that you are not supposed to take anything outside. We do not know who cooked this food for you, and they are made to fast, which is not, all these rules are not applicable for sons. For boys, they are not applicable. So I feel that only taking care of the girl is definitely not sufficient. We have to educate, we have to train their mothers also, because it is their mental block of mother which gets transmitted to the girl, and they behave like this, and they remain anemic. What sort of a future mother they can become? So as our chief guest, Dr. Shanta was telling, these are the basic problems with anemia, and that's why the anemia is not getting why getting irritated? They are in fact increasing, and we as a doctors, we are at the receiving end. We get the anemic patient, we treat it. We get the severe anemic patient, we try to modify our methods of treating. That's all. That's in our end. This is a holistic approach, and unless until every section of the society, I would like to narrate one webinar of Foxy in a recent past days, where when our president, Dr. Alpesh Gandhi, was telling that now for the COVID-19, everyone knows. In the villages, they know about the corona. In every street of a town, they know about the corona, this pandemic. But our anemia, is it not an endemic? It is not an non-corona endemic. When our 30 to 40% mothers are dying of anemia directly or indirectly, leave aside the morbidity. 66% of adolescents are anemic. It makes about 64 millions of daughters. Our daughters are anemic. About 50% of our population is anemic, and as compared to the USA, where only 6% anemia is there. So I feel that he was very correct, that we all have to do something. Otherwise, we are at the receiving end, will continue to remain in the receiving end. It is an holistic approach. When the government, the media in special, and every section of the society needs to participate. They have to be sensitized. They have to be sensitized for the gravity of the situation, gravity of anemia. At present, it is like that only we as a doctor and the little bit of the patient treating, they know about anemia. So I feel that this strong message should go to all these concerned who have to work for anemia, so that, as our chief guest very correctly said, that soon we want to hear that our country has eradicated anemia. I think I have taken too much of time. I may please be excused if I have taken that time. And I again once thank you all, and wish you and pray you for all to be safe on this critical pandemic period. Thank you so much.
Thank you, ma'am. Thank you, ma'am.
Thank you so much, ma'am. Ma'am, we have a question in the chat box. Can albendazole be routinely given to pregnant patients? And if yes, in which trimester?
I think the albendazole should be avoided in the first trimester, and the second and third trimester, yes, can be given.
Can we give iron tablet in first trimester for treatment of moderate iron deficiency anemia?
We can give oral iron, yes. But if you can make it to alternate days, I think it would be better. You would get a better compliance of the patient. But rest depends upon how much requirement you need for completing the iron stores.
With iron sucrose injection, do we need a test dose?
I think with iron sucrose, yes, you need to do a test dose, but if you use IFCM iron, then you do not need to do a test dose because of the low immunogenicity of that iron.
What will be the risk for patient with full-term pregnancy and hemoglobin 8.5 after 2 packed cell transfusion? But serum ferritin is still 6.5 and the patient is in labor.
Okay.
Does there is an increased chance of bleeding or increased chance of collapse of patient with slight increase in bleeding?
So I think after giving her even 2 packed cells, her hemoglobin is okay, it's 8.5. But yet even her ferritin is still low, very low in fact. So she would again be at a high risk again for your bleeding and PPH that could occur, or the involutions and all later on. She still carries that risk.
Ma'am, as such, what do you suggest? Iron tablets are better or capsule?
Anything could be better. It's basically the compliance of the patient which is going to matter. Because it's not the difference of the, it's basically the absorption, how much elemental are we are getting out of the tablet or the capsule. The format of the capsule or tablet doesn't matter, but how much elemental iron is it going to give us? That is there. Like to get a 60 milligram, you need around 500 of ferrous. So that is more important rather than this. And the severity, yes, you need to see the severity also.
Okay. Would iron tonics be more appealing to girls and women?
Not really. I think if they're very fussy, they don't want to take a tablet, only then, or some taste problems are there, then, yes, fortified foods and all, if it is there, then it's okay. Otherwise, they're not necessary that they have to take the tonics only.
Right. Thank you so much, ma'am. Ma'am, thank you. Too small a word to show my gratitude. I wholeheartedly thank our chief guest, Dr. Shanta Kumari ma'am, our guests of honor, Dr. Archana Verma ma'am, Dr. Asha Bakshi ma'am, our chairperson, Dr. Leela Joshi ma'am, and our speaker, Dr. Ritu Khanna ma'am, for all your time, the knowledge you shared, and affection for Ratlam.
Thank you so much, Leela ma'am, and congratulations and a happy birthday to you once again. It was so nice to have all your shares and experiences, and we really learned so much. Thank you, Manisha and Diha.
Thank you. Thank you.
I would also like to thank ICOG for giving us 1 credit point for this session. And a lot of words to thank all the Foxians for attending today's meeting and making this session a big success. We were 76 max at the peak of this session. And finally, lots of thanks to Team Pharmacent for organizing this webinar and being there with me day in and night to bear all my tantrums. Thank you all. Hope to see you.
Ma'am, Asha ma'am, and Archana ma'am also. Thank you so much to Ratlam Obsgyn Society.
Thank you, everyone.
Thank you. Thank you.
Thank you so much.
Thank you. Bye-bye, madam.
Bye.
Ma'am, I'm stopping the YouTube live video as well as this meeting. Okay.
अरे लाइव था क्या? अरे यार, तो नेक्स्ट टाइम से बताना, तो मैं पहले से बोल के रखूंगी कि YouTube पे लाइव होगा, तो फिर उसके लिए कोई लिंक शेयर करना पड़ता होगा ना?
वो डायनेमिकली तभी के तभी बनती है.
अच्छा है क्या?
हाँ.
तो चैट बॉक्स में डाल दिया नेक्स्ट टाइम.
हाँ, डाल देंगे.
नेक्स्ट टाइम मतलब अभी मैं छोड़ने वाली नहीं पीछा.
हाँ हाँ एकदम.